vision for Manchester includes being the healthiest city in the country. We're about the diametric opposite of that at the moment. We have some of the worst life expectancy anywhere in the country, and our vision for integrated health and social care won't resolve those things on its own, but will make a major contribution to having that healthy Manchester rather than an unhealthy Manchester. I think the way we want to provide health and social care services in the future, instead of starting from the services that happen to be available, we'll start with the patient and with people with care needs, with their carers, and then we'll build the services they need around them and their needs. Health and social care, from a patient's point of view, will be one service. We'll have a wholly integrated community, primary, acute, public health and social care service with the primary aim of preventing ill health, but when ill health does occur, being able to provide services to patients in the way that suits them best. I think for people who work in community health and social care, the next few years is going to be really exciting, because basically they are the future of health and social care, and they're going to be working with both health and local authority bodies to create a really exciting new service. Clearly there are also challenges, and not least the budgetary challenges that we're going to face over the next few years, but they are going to have a real opportunity to deliver services in a completely new way to the people who need those services. I think get a lot better outcomes from it and a lot more satisfaction.
People are living longer than ever before. What's more, they're living with a combination of complex illnesses which are increasing the cost of providing the care they need. Our current health and social care system can't cope with these growing demands. But this isn't just about saving money. We not only want people to live longer, we want them to lead happier, more fulfilled lives, and we don't want their health to hold them back. That's why the Living Longer, Living Better programme has designed the One Team model. It's the biggest change to the delivery of health and social care in Manchester since the NHS was founded in 1948. Designed by health and social care experts, it's a common sense approach that aims to ensure that people's individual needs shape all aspects of their care. Meet retired postman Frank. He's 78 and cares for his wife Maud, who also has early stage dementia, as well as looking after the family dog Pickles. Frank suffers from COPD, a lung disease that makes it hard for him to breathe, as well as type 2 diabetes and arthritis. Maud tells everyone she's fit and well, but actually she has a bit of angina and bad hips and knees from her arthritis. Maud hates a fuss being made of her, but struggles to walk Pickles. Consequently, they both call on their GP's expertise more than most and are frequently found at the hospital attending outpatient appointments, scans and blood tests. Frank regularly travels to different health centres, sometimes on the same day, to be seen by community health teams for everything from podiatry to physiotherapy and nutrition. But when his chest is really bad, Frank rings for an ambulance, which frequently results in him being admitted to hospital. On these occasions, Frank worries about Maud and whether Pickles is being walked. He then has to wait to be assessed by social services before he can even go home. The result? A lot of unnecessary time in hospital. One Team is designed to make the Frank care receives more joined up and less stressful. All Manchester's health and social care providers are working together to establish 12 integrated health and social care hubs in neighbourhoods across Manchester. Each hub will have a neighbourhood team consisting of social workers, active case managers, district nurses and primary assessors, among others, who will work together and share information to ensure that each individual's needs are fully met. One of these professionals will take overall responsibility for each person's care. In Frank's case, this is Helen, a district nurse who designs a care plan which everyone who provides his care can all access at any time, day or night. Helen supports Frank and Maud to manage their own conditions better so they can keep active and don't rely so heavily on social care and health services. On one of her visits, Helen noticed that Maud was a bit quiet and it was clear her knee was getting very sore. Helen highlighted this to the neighbourhood team, and without needing to attend her GP, Helen made sure Maud got some physiotherapy sessions and got her pain medicines reviewed. Maud was also seen by the local orthopaedic service, who arranged for Maud to have her knee replacement surgery. During this time, Maud felt reassured that Frank was getting the help and support he needed at home. When Frank's health takes a turn for the worst, Helen and the rest of the team quickly put in place the care Frank needs to get him back on his feet again, which means no hospital admissions. Frank has the peace of mind that should he ever be admitted again, Helen will make sure that Maud gets the extra support she'll need from social services, as well as arranging for someone from the local Good Neighbour scheme to look after Pickles. And because Frank isn't worrying about what might go wrong, he can focus on keeping well. One team recognises that some of the problems people face are less common, so services like reablement will be delivered at a locality level across North, Central and South Manchester, with teams located in the most practical care hub in that area. For the rarest conditions like sickle cell anaemia, separate specialist teams will provide care on a city-wide basis. So, what happened to Frank? The neighbourhood team meet regularly with his GP to discuss the best options to keep him fit and well. His community health appointments are scheduled to take place at the same hub on the same day wherever possible. And should he ever need to go into hospital, he knows he'll be back at home as quickly as possible because an integrated care plan already exists. The result? Frank feels more in control of his life than he has in a long time, happy in the knowledge that his care is being managed in the most joined up way possible.
The patient would be visited by the key worker and they would tell their story, a little bit about their past medical history, about their life, what's made them the person that they are today, and what's important to that person and what they want and see as important for their future and where they would like to be towards the end of their life sometimes. So all of that information was done through a patient story and was put onto something called GraphNet, which was an electronic care plan, which meant that if the patient turned up in A&E or if another member of social services or health went into that patient, they could access that person's care plan, and it just gives a brief synopsis of that person, short succinct story about where they are today, how they've got there, what's important to them, and it just saves time. And when you're meeting that person for the first time, you've got some background information, and it saves multiple duplication really.
We already have an idea of what the patient's wishes are. We know a little bit about the background. So being able to go out and see those patients with, trying to act seamlessly really, trying to continue that level of care that's already been implemented and make sure that they've got a more long-term plan in place. And the patients find that really positive because they don't feel that they're just being left after that acute episode of intervention. The care's going to be provided over a much longer period of time, and having that plan in place is, I think, sometimes quite comforting for the patient because it's something that's been agreed between them and between the healthcare professional or the key worker. So it's much more empowering, I think, as well.
We all have like a group meeting every morning, all our patients are on the board, and we will then sort of delegate the work out as to who needs to visit each patient, what needs to be done, what needs to be followed up, who's going to do the discharge. Then everybody on the team is aware of every patient on that board, what's going on with them, and then, like I say, who needs to follow it up will then go out, follow up, do their bit, and then hand over again. So it's all really streamlined the way everybody gets handed over to each discipline within that team. Because we have access to, or we have had access to, mental health practitioners, occupational therapy, physiotherapy, we can just do a very smooth verbal handover and it gets picked up straight away instead of that patient having to wait, and I think that again is massively beneficial to that patient.
They have a care package if they've got a dog at home, if there's any risks identified in relation to their mobility, falls, if they've got breathing difficulties, heart problems, what to do in certain circumstances so the patient knows where to go. But having access to the mental health team and the nurses, we know already what their medical background is, and it's good as well from the carer's point of view. So if they did go into A&E, there's none of this trying to ring round everybody. All that information's there to say, right, this person has care agency from Home Care Support or wherever. The key workers, Hilary Martin, social worker, or Jane, the nurse, let's speak to them and let's see if we can, speed up the discharge. Because if we know that some of the acute illnesses are reoccurring, there may be plans that we could put in place to say, okay, they've gone into A&E, they don't really need to be admitted into hospital, we can get them home and we can get the support they need from the GP and nurses. We can visit them the same day. If they need an increase in care, we've got access to that if needed via the rapid response service. If they need equipment, I don't know, commode or a hoist or anything like that, then assessments can be done.
Integrated care has changed the way we work. I think it's made us think much more about the patient proactively. I think it has stopped us spending the time reacting to problems all the time, and then we often only react when there's a crisis. So I think we're better informed. I think we are more in control of situations that we weren't. And I think the other thing for us is that these are often complex, difficult patients who demand a lot of time and effort. But when you've got a plan in place, that level of anxiety drops down because you're ready. You know what's going on. We need to understand that chronic ill health in a large number of cases across the whole age spectrum is mental health as well. So I think we need to keep them well engaged with that. And I think, to me, one of the most important things is that we manage the data that we collect, because this is the glue that sticks the whole thing together. And that integrates with our system in the practice, then everybody will start to use that. It becomes just second nature. And I think it's like, it's like our smartphone or whatever. It's with you all the time. You can use it. It's a part of what you're doing on a day-to-day basis. So I think what we've done for years and years in primary care is worked very much in silos and very much around primary care doing the health side of things, and then the spin-off has been, and often the difficult bit has been social care, mental health, trying to dovetail those things in together. And I think the patients have never really got a very joined up approach. And I think one of the things, to me, what integrated care really is bringing those people together. And if we can do that in a structured way, so that we're dealing with a cohort of patients that we are actively involved with, or those patients who are on the brink of our involvement, so the ones who are potentially going to go off, then we can anticipate it rather than react to it, and we can manage it rather than just respond to it.
When I've got a lot of things going on at the moment with illnesses and that, and you feel as if, even you go to the hospital and place like that, nobody seems to want to know. But as soon as Danielle, Susie and Debbie got on board, everything just sort of went into place. Everybody was doing things for me. I could pick the phone up 24 hours a day, especially when I had one of my problems was get really bad and I was ill. I could pick the phone up. There was somebody always at the end of the line, and always somebody would come to my door. You don't need to go to your doctors. As I said, when even say your blood pressure's high that morning or you just feel a bit dizzy, whatever, you can just pick the phone up. There's somebody at the end of that line, and that's what you need, especially during the night. Because I've had a few bad falls, like at night times. I pick the phone up and there's somebody there for me. Or they'll just come to the house, and when they come, they listen to you. My tablets have all been sorted out for me now. Hospital appointments have been done. I even had a cooker that I couldn't even cook because I couldn't reach down to it. Danielle got me a cooker. It's just, and somebody to listen to you.
Yeah.
I mean, I'm not too bad. Like I say, I've got a family support around me, but there's people out there got nobody at all. I got depressed. I didn't know I was depressed, till the girls started coming out. I got depressed. I didn't want to do anything. And I'd also had 3 very bad bereavements the year before, which was really bad. My dad, my sister-in-law, they were really, really bad. Danielle got me through all that. I mean, I could go to my family, but they're already grieving themselves. Danielle didn't know anything, and she sat and she taught me through it. And on their anniversaries, when I was really down, because I suffer from IBS, which I think a lot of it's caused through stress. So when I was stressed, this IBS was really, really bad. But as soon as I picked the phone up and they come out, I noticed I was a lot better in myself. I think it takes it off the doctor, them coming to you. I honestly do think you don't need to go to your doctor as much, with the little daft problems. And sometimes you don't want to go to your doctor because you feel as if you're putting on them. Where with the girls, and the lads, you don't feel that way because they don't make you feel that way. Even the littlest problem are there for you. What they did was just the right thing for me. It was the right thing for me, I mean, there might be people out there wanted more doing, but for me, it was just perfect.
When the neighbourhood team was set up, our doctor, Dr. Ashworth, came to the house to ask Bernard personally and explain what was going to happen and ask him if he would like to have the service, which of course we accepted. And the whole idea was to keep him at home rather than having to go to A&E, and it certainly has helped. I mean, he still had to go, but he's not been in overnight for some time. We don't really want to go to the hospital. I don't want Bernard going. He's not very happy when he goes into hospital. He becomes confused, and he is not normally, he is absolutely with us. If I am on my own here, it's wonderful if I can call a rapid response team, and in the past they have come and they have helped me. I'm not fit to lift Bernard or handle him, but it's just brilliant to have someone to help. But the rapid response team is wonderful to know that it is available, and it's lovely to have somebody like Tony on tap to get advice from. Tony here has got facilities for me that I wouldn't have known existed. One is a lever on the side of the bed, which helps Bernard because his mobility is very poor. Another thing is a urinary arrangement that makes it a lot easier for him. Our doctor is very good, but these kind of helps, of arrangements, are things that would never have come our way if it hadn't been for the assistance from Tony.
We could do a lot of what we want to do in terms of integrating in health and social care without devolution. Indeed, Living Longer, Living Better started long before the devolution agreement with the government. I think what devolution will allow us to do is to join up health and social care a lot better with other services, the things that are trying to get people back into work, the work we're doing to support troubled families and to turn their lives around. Health and social care in a devolved system will not only be integrated with each other, but they'll be integrated with those other areas of service provision as well.
We think we can get better services quicker to people if we concentrate on where they live in their communities rather than the organisations that are providing those services. It was about integrating those services together, and my role is to try and encourage and work with the 37 different statutory bodies in health and social care. That's the local authorities, the CCGs and the NHS provider organisations, that we're all focused on one thing, which is improving the health and wellbeing of the population of the whole of Greater Manchester.